So I'm aware I stand between you and coffee, and I'm also kind of the morning's going on, so I hope you're all still awake. And I want to tell you about some of the really exciting evidence that's coming out in this area. So I'm just going to give you a quick context, and then I want us to think about what interventions can be delivered to change the outcomes for patients. Some of the challenges around that, some of the evidence that supports it, and some of the considerations around how we might identify people with palliative care needs. Okay? So we've heard already some of the context in Ireland, and I want to really stress a few things for you. So the worldwide prevalence of heart failure is high. And sometimes you hear people say heart failure is getting less, and sometimes you hear people say heart failure is getting more. Okay? Both are true. And I'll tell you how. The incidence is getting less, but the prevalence is getting higher because people are living with it for much longer. So both are true. And just ask the person who's talking to you, are you talking about incidence, new cases, or are you talking about the numbers of people living with the condition? So in the US, we have data on how big an increase in prevalence there is, and it's really massive. To go from 5 million to 8 million. So, it's kind of a way over 60% increase. And it's also true in developing countries. For those of you who do have links with developing countries, the incidence and prevalence of heart failure in some of those countries is increasing. It's also worth thinking about what kind of a population this is. We heard a little bit from Karen on this, but these are mostly older people, and they're mostly got multiple morbidities. So they have renal impairment, and they have diabetes, and they have everything else. And I think one of the things we've got to move away from is asking services, do you deliver to cancer or non-cancer, and expect one diagnosis? We need to start to find a way to say, actually, we've got a lot of people where heart failure is a significant component, but it's only one component of those problems. So that's a real challenge for the future. We've also heard that people don't always die of their heart failure. They die of other things because they've got all the comorbidities. But if they do die, they might die suddenly of a cardiac arrhythmia or so forth, and that's a smaller number. But the majority who do die in relation to their heart failure die with progressive pump failure. And so that means you die with an increasing burden of symptoms, hospitalisations, struggle with all the social and psychological impact of that. Okay, you know that already, but I just want to emphasise it. So if you're getting a lot of people who are living longer with their condition, you're getting more of that. Okay, so the burden is there, and we've really got to think how we address it creatively. So this is from a really interesting paper by Colleen Mcllvennan and others, and it draws together some of the evidence, and I would recommend it to you. It's in the BMJ, and one of the things I want to draw your attention to is this figure, because I think it gives quite a good perspective to keep in your mind of what we're needing to be thinking about. So if you look at that orange blob, that is about the transition. It's about moving from the kind of more active management of their cardiac condition into a phase where many of the active interventions are really not going to do a huge amount. Okay. Now, people will argue where that sits. Does that sit up here or down there? But the most difficult thing is, when do you know prospectively that somebody's going into that yellow blob? And that is the hard part. And for those of us in specialist palliative care, we rely on other people to think about that. And as we've already heard, they don't think about it. Challenge number one. The other challenge is the one that Karen and others have already drawn attention to, which is we've got a clinical course in the top wiggly line, okay, and it wiggles all over the place, makes it hard to know when you're going into the yellow blob. But actually, if you look down the bottom, we've got the care. This is a care trajectory down here. And you've got the cardiac care, which is a lot at the beginning when they're first diagnosed, and then it wibbles along in reflection of what's going on with decompensations and so forth, and then it goes into the yellow blob. But now what we want to draw people's attention to is the blue line, which is the palliative care type interventions. Now I don't mean necessarily specialist palliative care, I just mean palliative care in its general sense. They're parallel, so they start before the yellow blob. Okay, so there's your second big challenge. How do we get people to think about introducing that blue line way before they get to the yellow blob, because it can make a difference. So you can begin to see on this slide some of the challenges. How do you know you're going into that blob prospectively? How does your cardiologist know that? How do you identify it? And how do you introduce the palliative elements of care all the way through, probably into some increased engagement with specialist palliative care if you become more complicated? Yeah. So just think of that and bring it to your mind when you're trying to think about what's going on. So I've said some of these challenges, the context of comorbidity, recognition of that transition period. We've already heard a little bit about the complex decision making that the more technical interventions are introducing, and there's huge advances in some of the technical interventions, so that things can be done in the context of older age and complex comorbidities, which couldn't be done 1, 2 and 5 years ago, making it even more difficult for those conversations, which we'll hear more about. We've heard already about the collaborative working, because that's a key. And then we've heard a little bit also about the social perspectives. What is heart failure? If you ask Joe Public going along the street, what is heart failure? Well, I don't know that anyone knows in the public what heart failure is. It sounds bad. What does it mean? Something wrong with the heart. But does it mean you're going to die? Well, actually, if you look at the statistics, it does. Okay, you may not die tomorrow, you may die sometime ahead, but you're going to have a shortened life expectancy. And it means also that these people and their families are experiencing frequent decompensations and hospitalisations, and they get used to that. So to then suddenly come along and say, well, actually, we think you're deteriorating or things are getting... Well, actually, he or she was in hospital last year or last month, and we were told it was all very bad, but actually they've survived. So all of those things are important. Now I'm going to talk about evidence because I'm a researcher, and I want to talk about two types of evidence: effectiveness and cost effectiveness. So effectiveness is what works. Now cost effectiveness is not money, okay? Cost effectiveness is about what are the resources used to ensure that you deliver what works. Okay, different question. And then I'm going to touch a little bit at the end on how you think about identifying people, that challenge on the previous slide. So, there have been a wealth of descriptive and observational studies. We've heard about one of them. We've heard about the action research from Karen. And there's a whole host of other studies out there in the literature which are descriptive of need, or which are observational, or which have a non-randomised design. But I'm not going to talk about them. Basically what they all say is that there's a lot of need out there, and that we think we can do something about it. But we're not quite convinced of, the evidence is not yet convincing from that. What I do want to talk to you about is 3 randomised controlled trials. And I don't always think randomised controlled trials are the answers to things. People have put them at the top of the evidence pyramid, and I think in palliative care they're not at the top, they're one of a range of tools. But if you want to understand whether a service or an intervention around managing heart failure is going to work or not, you do want an RCT, because then people are randomised, the bias is eliminated, and you know whether it works or not. 3 studies: Sweden, the US and Hong Kong. I've actually colour-coded them. Sweden is green because there's lots of trees there. Hong Kong's got lots of water around it. And US I couldn't think of a colour, so I left it black. Maybe the most densely populated, I don't know. Probably Hong Kong is, but hey. So these came out in 2014, 2015 and 2016. Okay, before this time we didn't really have RCT evidence. Now, don't forget that we're not talking RCT of drugs or even a device where life is relatively simple. We're talking about a randomised control of a complex intervention. So a package of things which are given to some people and not given to another group of people. Complex interventions, RCTs, are difficult because you have to define what it is that's in your group of intervention package, and you also have to monitor the extent to which it's actually happening, and you often have a little collection of things and you don't know which is the one that's the active ingredient, the yeast in the bread. So it's a really tricky one, and what happens with these studies is you do RCTs, and then later, once you've got the answer with a complex intervention, you might do more studies to work out which bit you can drop so that you can refine it down and make it more cost effective. So it's a slightly reverse way of doing things, but this is a complex intervention. And I'm pulling together for you all three studies in one slide. What are these patients actually getting in these studies? And what is fascinating to me is the commonality between the three studies and in three separate countries and the results. So it's nice because you can say the results are all saying the same thing, but there are a bit of differences. So first of all, who are the patients? They're a New York Heart Association 3 and 4, and then they've got various other things. One study, the US study, wasn't that discriminatory about who it was giving it to. It was just in patients with heart failure. But the others, you can see the kind of criteria they used. And I only put them up there to say, think about your population. If you're trying to identify a whole bunch of people for whom this might be useful, here's a few clues about what those things might be. And the one that's very useful is hospitalisation. Because as soon as people start to be coming in once or twice or three times for decompensated heart failure, they're going to need palliative care. End of. Okay? So, but there's a few other things in there if you want to look at them. Size of these studies. Now, I'm going to tell you the numbers in them. 72, 232 and 84. What matters to you about the numbers is not the actual numbers, but whether these studies were appropriately powered. So did they have enough people in the study to give the answer to the question, does it work? All three of them were adequately powered. That's all you need to know. You don't need to know the actual numbers. You do need to know whether they're similar to your populations. Okay, so mean age, 75, 80-ish. A slight preponderance of male, as you would expect, but the causes of the heart disease were different. Actually, in Sweden they had a lot less ischemic heart disease, and interestingly they didn't report it in one of the studies. But just to say, they may or may not be similar to your populations, probably not hugely different. And then what kind of care did they provide? So this is what's in the package. If you're going to do something, what's in the package? So in Sweden they nominated a responsible doctor and nurse, so they were named for that individual. They had a thorough assessment at the start of their physical, social and spiritual needs, sounding like palliative care to me. They had after that a nurse meeting which was patient-centred care, which focused quite a lot on preferences and plans for the future. They then had a fortnightly discussion by a multidisciplinary team which included cardiology, plus sort of informal discussions and information sharing between times, and they were followed up. They don't give a lot of detail about the frequency of follow-up. They also use validated questionnaires, and I include this because they didn't just use validated questionnaires to find out the answers to whether things were working. This of itself may well be an intervention, and we'll hear more about that from Pauline later. So I think that has to be regarded as part of the package of intervention, because we know if you give someone a validated questionnaire to elicit symptoms but do nothing else, that improves their outcomes. Interesting. So I think we have to regard that as part of the package. What did they do in the US? thorough palliative care assessment, they called it palliative care assessment this time, of physical, social and spiritual needs, and then they did further reviews according to need. So if you had a lot of needs, you got a lot more review, and if you had relatively less, you got less. They also almost all had disease-specific advanced care planning, similar to the previous one, and they used validated questionnaires again. What did they do in Hong Kong? They did what they called case management with periodic review. Very similar. Discussion of end-of-life issues, which was explicit. Thorough assessment of physical, social and spiritual needs, sounding very repetitive. Discussion of treatment preferences, multidisciplinary review, an integrated model of care. I don't know that the integrated bit is any more than they've described here. And validated questionnaires. Okay, so if you're going to do something, you know, the question is, what do you do? It's very easy to get taken off track and do something slightly different that everybody thinks is a good idea. But this is what you need to do, okay? So, thorough physical, psychosocial, spiritual, psychological assessment, which you all know about in palliative care, a discussion of priorities and preferences and where that's going to go, and some kind of follow-up, but with a multidisciplinary driver of those reviews and discussions, plus the validated questionnaires. That's what you need to do. Even one validated questionnaire is fine. And I think Karen's point about evaluating things as you go along, that will give you the ammunition to evaluate it as you go along. So, what did they find? And again, I'm trying to bring the three studies together to give you the story. Quality of life in the Swedish study improved by about 25% over 6 months. Pretty impressive. Good effect size. Symptoms improved, so overall symptom burden by about 18% in the same time scale. Only one symptom individually had sufficient weight to improve on its own. Function improved, and this is the only study where they got any change in function, so the class changed. Hospitalisations, and remember they're looking at this over 6 months, remember that, both the hospital days and the number of admissions were less. But they had more nursing visits because of the way they'd set up the follow-up, but actually less doctor visits and less doctor contacts. In the US, they had smaller improvement in quality of life, but they had much shorter follow-up, so they only went to 3 months. And what was interesting was that they found there were larger improvements in the physical component of quality of life and smaller but later improvements in emotional. So it probably takes longer to get some of the emotional support through. They also saw overall symptom burden improving, slightly less, but you'd expect that because it was a shorter follow-up, and particularly breathlessness, anxiety and tiredness at 1 month and 3 months, and pain at 3 months, but interestingly not pain at 1 month. Less distress, but that was a small effect size. And then no change in the 30-day inpatient readmissions, but they only looked at that for 30 days. And it's very interesting because the other study looked at it over 6 months and saw a big difference, but it was mostly later. So you have to have time before you see the difference in acute hospital use. What about the Hong Kong study? Again, improved quality of life at 4 weeks and 12 weeks. They got a moderate effect size. Improved overall symptom burden, really quite a dramatic increase, particularly depression and breathlessness. Didn't see any change in function, as you perhaps might expect, and a lower 12-week readmission rate. They didn't see that at 4 weeks, which is comparable with the other study. So you can begin to see the patterns. So you've got to do this particular package of interventions. You may not see the change on acute care in the first 4 weeks, but certainly 3 to 6 months out you will. You'll certainly see an improvement in quality of life, a reduction in symptom burden. It may be hard to pick up if you're only measuring single symptoms, but certainly single symptoms will improve over time. Okay, so there is your evidence. And when you go to your services back home to argue the case for where you're going forward, give them this and make sure you stay on track to try and deliver some of the components that we know work from this evidence. The other question is that, and I think from the cardiology point of view, people worry about this. They sort of sometimes see palliative care as being a naysayer about stopping things. I was very delighted recently because I met a consultant colleague on the wards who said to me, that patient you've just reviewed, I really wish you'd make your mind up. Are you wanting to stop things or to start things? And what he meant was that sometimes we come along and say stop things, and sometimes we come along and say start things. And I was really pleased by that, because it's different. You know, we don't actually always go along and say stop things. We should sometimes be saying, this person's preference is for active treatment, and let's just make sure that happens for them. We don't want to be the, now stop everything because they're palliative. That is not what it's about. And I think the two ways to tackle that are that wiggly blue line, early intervention. That's what palliative care is about. It's not about the last days of life, so challenging that assumption, but also thinking carefully about when it is that we advocate for things as well as advocating for stopping things. And I think that's a really important point. But people do worry, do you get worse survival if you go on a palliative involvement pathway? And none of the studies show any adverse effect on survival. I would say that the Hong Kong one don't report it, but they do report loss to follow-up, which is mainly due to death or deterioration. And you can see it's much higher in the control group. So we can rest assured that this does not make your survival worse. It may have a neutral effect, if anything. And what about cost effectiveness? Okay, so the Swedish study, which was perhaps the best designed of all three, had a group looking at cost effectiveness all the way through. And they found a gain of 0.25 in the quality adjusted life years in the intervention group. That's quite a big gain in health economic terms. There were significant cost reductions in the intervention group, mainly because of the reduced hospital care. And I've just put some euro figures on there so you can see the proportions. They needed more GP input. They needed a lot more professional input from nurses and other professionals. They needed much less hospital care, and hospital care is expensive. And they needed reduced emergency transport. It's a good costing study, so if you want to have a look at it. So you can also put the case across when you're trying to argue for the services that this is not only effective care, but it is very cost-effective care. I'll talk about that a little bit more in the next slide or two, but what we certainly need to be providing is detailed, thorough assessment of physical, psychological, social and practical needs. We certainly need multidisciplinary discussion and review, which includes both cardiology and specialist palliative care, and it may include others, depending on the setting. It may include primary care, it may include care of the elderly. And we probably almost certainly need to use validated instruments so that we can assess the effect of what we're doing, but possibly also for the benefit they offer themselves. And I think there's certainly got to be a component in there around preference discussion. These things will then improve for patients. So symptom burden will improve, quality of life, satisfaction with care, which I haven't discussed, but it is convincingly shown to improve. Probably greater impact on physical than emotional aspects of care. There isn't much evidence around change in function or frailty, but I want to draw your attention to the fact that none of these packages that I'm talking about had specific allied health professional involvement or a rehabilitation element. And I think that's a really interesting area for the next studies, because we have got quite good evidence emerging in the Cicely Saunders Institute that you can reverse frailty in older people with multimorbidity if you do the right things. And the right things are about rehab type interventions. So if anybody's keen on a study, there's one for you. It's likely to reduce hospitalisations and emergency department attendances, which again I haven't talked about, but they go down as well, and it doesn't have the adverse effect on mortality. I wanted to just talk about validated instruments, and I'm not going to steal Pauline's thunder, but I did want to say that we have a validated instrument that we've developed at the Institute, and I always feel a bit uncomfortable because I sound like I'm blowing our trumpet, but it is actually the one that's most popular with patients. I've just been part of a study with St Christopher's where they had a plethora of different measures, and the patients all wanted the IPOS but could let the others go. So it's important, but we are developing a heart failure version which is like the standard integrated patient outcome scale, but it also has some added symptoms, and they relate largely to renal and cardiac function. So restless legs, itch, cough, difficulty lying down to sleep, palpitations, edema, waking with breathlessness and so forth. What we haven't done yet is a full validation study using this measure, and perfectionists that we are, we want to do a full validation study before we release it to the world. But I think what we're probably going to do is release it for clinical use with the understanding that it's not yet fully validated, and that may be in the next 2 or 3 months. The advantage of IPOS is that it has an opening question which asks people for their own main problems and concerns. And that's really helpful, because if you ask this of patients and staff, even specialist palliative care staff, there is only 40% agreement with what the main problems and concerns are. And I think we need to keep asking people that very explicitly. And we often assume we know once we've done an assessment, but we don't. So I would say these 3 studies together really give us some evidence base that's very convincing about what we can do and the cost effectiveness of it. But I would also say they raise other questions. Do you remember I was saying at the beginning, in a complex intervention, you want to think about what components you can drop to make it even more cost effective and easier to deliver. So there are studies now to be done about which are the critical components of these ones that I've mentioned. And there's also a piece of work that needs to really be done to understand who are the more complex people and who are the less complex people. And when is it that we need to support, as Karen says, indirect care, helping cardiologists or primary care or care of the elderly deliver to symptoms and other issues, and when is it that we actually need to be getting directly involved to provide direct care? And that is really an unanswered question, and I think it was a great overview at the beginning of that discussion in the 90s about cancer, non-cancer. The discussion now is how do we systematically understand who is the most complex and needs specialist palliative care directly, and who actually could be delivered care as a palliative care approach within cardiology or primary care. And don't forget that a lot of these patients are not even known to cardiology, let alone palliative care. They're out there in primary care struggling with symptoms and issues, and that's a real challenge for all of us. So there's a really interesting editorial in the New England Journal of Medicine by Amy Abernethy and Tim Quill, which actually discusses some of these issues around how do you think about what can be done by whom and what's the appropriate level. And I think we need to be really thinking about this in palliative care. So what's core elements that we can support other people to deliver, aligning with treatment goals, core symptom management, quality of life, rehabilitation, practical supportive aspects of care. So how can we prompt those things to happen when they sometimes happen and they sometimes don't? And then what is it that we think is truly specialist palliative care intervention? So difficult and resistant symptoms, interacting symptoms, distress, psychological aspects, the whole kind of total pain area, but in cardiac disease, maybe total breathlessness, which has not really been a concept that's been discussed. And then some of the challenging ethical family conflict, those difficult times, and how, what's the right thing for management. Now that's quite challenging because palliative care has to grow up to be even more mature to let go of some of the more routine stuff that they do, and it's easier to hang on to the routine stuff because it's a comfort zone. But I think that's where the specialty is at the moment. Sorry, going the wrong way. So just to say, I think wherever you are, you have to think about which domains of groups of people are the right ones to draw into this. And it will be very different according to your setting and also your local services. There's also this issue of how you identify people. So remember back to that diagram with the yellow blob and the lines. It's that bit of how you identify those people prospectively so that you can prompt palliative care considerations, be they generalist or specialist. And I think although prognostication is really not that helpful, so trying to say, are they in the last year of life? Have I got that right? Not helpful. We should be going on needs and not prognosis, especially if you think about blue palliative care involvement line that we want to go along all the way through, not just after the transition. But there's a really interesting study I would draw your attention to, which is looking at what happens if you take a group of community-based heart failure patients, 138 of them, and you apply gold standard framework criteria. So you say, surprise question, do I think they might die in the next 6 to 12 months? Do they have difficult symptoms despite optimised treatment for their heart failure? And have they had 2 or more heart failure related admissions? They actually found 86% of these people met those criteria. So it's a huge number of people. When they followed them up for 12 months to find out if they died, you can see there's quite high sensitivity, so that's identifying the true positives, but quite low specificity, as you would expect. Relatively poor positive predictive value. So I say don't use this to predict who's going to live, but if you want to use it to predict who might have palliative care needs, very helpful. And it's very similar to the kind of entry criteria we're looking at for those studies. So one could use 2 or 3 quite simple criteria to help support the cardiologist or the primary care or care of the elderly. Who is it you need to be really identifying? We did very similar work like this in renal failure. We thought, and certainly some palliative care specialists were really worried that the floodgates would suddenly open, but actually they didn't. And they didn't because we were supporting the nephrology teams with symptom guidelines, how to have conversations, communication, etc. All the sort of things that Karen's Action Research Project was tackling. And actually we only ended up with 7% of the population being referred to specialist palliative care. So it's about getting that piece right to make sure that it's the right balance. So we need models of care which are based on problems and concerns that people have and not on prognosis. Let's move away from prognosis. We don't know how to do it anyway, given that wiggly line. Let's think about the gold standards framework type criteria to screen and identify people, or even something like IPOS, and Pauline would tell us more about using that to identify people's needs. I think there's a real cultural distinction still between a disease-orientated approach and a patient-centred approach. And I think we have to be realistic about that cultural kind of conflict in professional worlds. If you've thought all of your cardiology life about managing diseases and interventions to evidence-based to make that better, it's very different to then say, well, actually, I've now got somebody with comorbidities, not sure the extent of their ejection fraction, not sure whether they've got preserved ejection fraction or well, but they've kind of got heart failure in there somewhere. I'd really like to know more about that so I can be evidence-based about what I do for it. Actually, now we're saying this is really patient-centred. Let's think about the problems and concerns people have got and work that way. Somehow we need to do a bridging to meet in the middle, but it does have to be centred on what's actually happening for people and how we address that. And I think the more we work collaboratively, the more we learn. We know what to do, so that would be my challenge to you. We know what to do now, let's go and do it. How can we go back and really get this embedded into services? Start small, challenge people, give them the evidence, and really think about how we can make it work. I think we have to do more work on how we can screen people, especially the people in the community who are not really known to anyone apart from their their GPs and maybe not seen as often as they might be. How can we now refine some of these models of care, which is the active ingredient? I really think this issue about rehab, changing the patterns of frailty, really exciting. And then how do we address the needs of the most complex and target limited resources, which is effectively what we're all working with, to the people who have the greatest need. So I've given you the references, and I think the slides will be available afterwards. And I wanted to just thank Miriam Johnson, who some of you may know, who was really helpful when we were talking through what were the key messages for this talk, so thank you. But also Paulina and others.